Assalamu alaikum, everyone. We'll be talking today about palliative emergencies. This is part one, and there's another one will come very soon, inshallah. Um, these are objectives, that we're going to talk about during the presentation. We'll start first with the definition because it's kind of a little bit confusing. A palliative care emergencies are a little bit different than medical emergencies and oncological emergencies. These are events, both cancer and non-cancer, related that demand same type of immediate remedy or action or cause acute exacerbation of symptoms that affects the quality of life. So these are mainly, quality of life emergencies. I did work on these emergencies from different sources, and I was able to gather around 22 palliative emergencies. Now, there might be more. I'm not sure, but I'm just saying, I think I gathered a huge number of these emergencies. And we'll talk about the first 11 of these emergencies, the one on the left today. And then part two will be the rest of the 11 emergencies. So we'll start with hypercalcemia, which is a very common uh, problem we see in palliative setting. Hypercalcemia, guys, affect 30% of patients with cancer. Approximately 50% of these patients will die within 30 days of hypercalcemia diagnosis. The most common cancers are squamous cell cancers of lung, head and neck, esophagus, breast cancer, renal cell carcinoma, lymphomas, and multiple myelomas. The mechanism is rather important. There's the commonest one is humoral hypercalcemia of malignancy, where there is a secretion of a parathyroid hormone related protein by malignant tumors, and this comprises around 80%. Local osteolytic hypercalcemia only affects 19%, while vitamin D secreting lymphomas is only 1%. I just put here some of the lung paraneoplastic syndromes for you guys to review here. And this is basically, the pathophysiology of hypercalcemia. It starts with the tumor cells, releasing, different parathyroid hormone-related proteins, and this can cause a chain of reaction here. Or local osteolytic effect, like bone metastasis. The clinical manifestations, of hypercalcemia depends on the calcium level. So we have mild, moderate, and we have severe. And if you want to change this units, the milligram per deciliter, like in some countries, they use the system international, like Saudi Arabia, for example. So you divide by 4, okay? So 12 by 4, it will be 3 millimole per liter. But anyway, mild hypercalcemia, really, a little bit of constipation and fatigue. Moderate hypercalcemia, there will be more effects like anorexia, nausea, muscle weakness, and delirium, hypoactive delirium. All right. And severe hypercalcemia, there will be more of progression of symptoms. So, what are we doing about hypercalcemia? We need to treat it, even in a palliative setting. Start with normal saline. Calcitonin is useful in the first 48 hours. Bisphosphonates is the mainstay of treatment. The most commonly used are pamidronate and zoledronic acid. Steroids are useful in lymphoid malignancies, and denosumab is effective in cases where the hypercalcemia is refractory to bisphosphonates. Sometimes, in very advanced cases, the decision is not to treat hypercalcemia may be appropriate. Remember, hypercalcemia causes, hypoactive delirium. The patient is usually, we call it like pleasantly confused. They're not hyperactive. They're not, so they really die in peace. So even if you leave them alone, nothing is going to happen. Calcitonin, the biggest issue with the calcitonin is allergic reaction. And it's only useful in the first 48 hours before the bisphosphonates, start to kick in. This is the zoledronic acid. Um, of course, you guys are aware about zoledronic acid, right? So this is a very famous drug that we use all the time for hypercalcemia. And one of the problems, it can cause osteonecrosis of the jaw. You have to have a pharmacist in your palliative care to kind of guide you the dosage, especially with renal impairment. And this is the other drug that we talked about, the denosumab or Prolia. Okay, this is used every 6 months, and that's the nice thing about it. And it's injected subcutaneously. Okay, we're going to jump into another important topic, which is serotonergic syndrome. And from the nerve, there is increase in the serotonin level, which can cause autonomic instability, clonus, hypermetabolic status, diaphoresis, hyperreflexia. Uh, Serotonin syndrome usually is a preventable drug-related complication. Tachycardia, hypertension, fluctuating vitals. It's actually considered as a medical or palliative emergency. And we have criteria, for that. Um, you know, you might want to use these criteria to diagnose serotonergic syndrome. Very important is to know the difference and the differential diagnosis. So you have other conditions that can give you a similar picture, like anticholinergic syndrome, neuroleptic malignant syndrome, malignant hyperthermia. This is something that we see, in anesthesia with inhalational agents and succinyl choline. Okay, so you're gonna tell me, okay, well, probably I will not see it. No, you can see it. If this patient had surgery and in the post-operative period the patient was transferred to your ward, you can get malignant hyperthermia post-operatively. So you need to be aware of it. Hopefully, you will not get it. It's rare, but it can happen. The neuroleptic malignant syndrome is basically from, dopamine antagonist drugs. And anticholinergic toxidrome is from intoxication with anticholinergic drugs. So these are the medications that can interact and give you serotonergic syndrome. You should be aware about it. We use these drugs all the time. Okay, so there's no excuse that you miss this condition. Okay, so you have a drug like linezolid, for example. and it's a strong antibiotic. It can cause serotonergic syndrome. These antidepressants, the SSRIs, and the TCAs and selective norepinephrine reuptake inhibitors, all of these can interact with each other and cause. And there's just, you have a host of drugs. Also, even you have herbal medications such as St. John's wort and the Panax ginseng and tryptophan. So basically, the treatment is supportive, benzodiazepines, and sometimes we give serotonergic antagonists such as cyproheptadine, which is an oral drug basically, and it's available. It's cheap and available. Okay, tumor lysis syndrome. Okay, a very famous syndrome here that we see with tumors that have high cell burden here, and they receive like chemotherapy. So we see it like in lymphomas and leukemias. They are characterized by high blood potassium, high blood phosphorus, high blood uric acid, high urine uric acid. However, the calcium is low. Okay, and usually there's nephropathy related to the uric acid here. So remember these labs, because these are your key for the diagnosis. So everything goes up except the calcium goes down, and these are the main causes of tumor lysis syndrome. The most important one is chemotherapy, 58%. Again, with chemotherapy in these tumors, there is a release of DNA and thus purines, phosphorus. Now, the management is basically giving, allopurinol or resburicase. Okay, the allopurinol is a xanthine oxidase inhibitor, and resburicase actually facilitates the change of uric acid to allantoin. So supportive measures. Again, allopurinol and resburicase is an alternative to allopurinol and usually reserved for high-risk patients. Okay? Now, if these patients don't respond, you can proceed with a hemodialysis, which can actually remove up to 50% of, the uric acid in a 6-hour treatment. Okay, jump into another important emergency is the pathologic fractures. And usually a pathologic fraction happens with normal activity. So this is how you first get it here. This is a patient that had normal activity and had all of a sudden a fracture here. So in palliative care, there are many risk factors, including osteoporosis, primary bone tumors, and metastatic disease. This is an example, humeral fracture or femur fracture. Of course, the fracture that affects the lower limb is more serious because these are the weight-bearing bones. So the patient will not be able to ambulate, guys. But if I have a fracture or humerus, even if I don't treat it, it's not a major issue. You can just wrap the arm and you can live your life with it. So just kind of give you an idea. And there is a criteria called the Mirel criteria, and it's frequently used by orthopedic doctors to predict whether this patient needs fixation or not. And there's another criteria called the SINS, the spinal instability, score here. And this one is very similar to Mirel, and in fact, actually, um, it's used for the same purpose. So, what are we doing for these, fractures? We use again, bisphosphonates. So this brings us to another use for bisphosphonates in palliative setting. And sometimes we do interventional procedures that can help with fracture, like vertebroplasty and kyphoplasty here. All right. So surgical options are also available. Like pinning the femur, for example, uh, can be done. I've done. I've seen a lot of these when I was back in during my anesthesia life here. 20 years back. It takes 15 minutes to do this procedure. I mean, from experienced orthopedic doctor. And then you have vertebroplasty and kyphoplasty are done by interventional radiologists or pain physicians, interventional pain doctors. With this, we inject cement inside the vertebral body, and this stabilizes the vertebral body from one angle, and the other angle, it produces heat when you inject the cement, and this cement actually will kill these small sensory fibers in the vertebral body, and this is the theory behind the mechanism of action of cement: stabilization and burning the tiny small C fibers in the vertebral body. Okay, dyspnea. Dyspnea has multiple names, like shortness of breath and breathlessness. I like the word breathlessness because it's easier to use for patients with, to communicate with patients. So usually dyspnea is caused by cardiovascular or pulmonary causes here. All right. What's more important for us is the dyspnea crisis, which is basically defined as sustained and severe resting breathing discomfort that occurs in patients with advanced, often limiting illnesses, and overwhelms the patient and caregivers ability to achieve symptom relief. I usually tell my fellows, you know, a dyspnea patient, inside the inpatient unit should not go home. Okay, a patient in dyspnea crisis, I mean, this is something very difficult to handle at home. Okay, so if you have a patient in your wards has a dyspnea crisis, please do not send him home, okay, until he becomes stable. And this is basically pathophysiology, of dyspnea. There is an abnormal lung and chest mechanics with impaired gas exchange, and this usually leads to dyspnea. So what do we do for dyspnea? There's a mnemonic for it, is breathe, okay? Treat the bronchospasm, treat the, RALs with diuretics. If the patient has effusion, do thoracocentesis. If he's obstructed, you can do stenting, you can do bronchoscopy or tracheostomy. Thick secretions, use anticholinergics. And if the hemoglobin is low, and this is one of the main causes of, dyspnea or breathlessness, is anemia. Okay, we see it all the time. This is very common. All right. So sometimes in the palliative setting, I just give blood for the fatigue and dyspnea. It's just, for comfort measures. I'm not seeking cure here. All right. So this is some of the gadgets we use: stent, tracheostomy, and so forth. We have an algorithm similar to the WHO algorithm for pain, you know, and you can see here it starts with, optimizing bronchodilators, add non pharmacological techniques such as fan relaxation techniques, pursed lip breathing, paced activities, which means, you should teach the patient to pace their activities according to their capacity. And then you can give opioids, which is the top of the pyramid here, plus or minus anxiolytics. So I want to point out that opioids is not your first choice. I know we use opioids a lot in palliative care, but it's not our first thing to use. When you have acute crisis here, acute dyspnea crisis, this is your last resort to use opioids, small dose opioids, and we use smaller doses uh, you know than pain actually. And what it does actually, it works on the complex called Boltzinger complex, which is part of the inspiratory center. It dampens this part of the brain and reduces the anxiety with breathlessness here. Okay, death rattle. So I'm sure all of you are aware about death rattle here, the work in palliative setting. And it basically, death rattle could be a result of saliva and bronchial secretions accumulating in the throat and upper chest. Really, it doesn't really impact the patient uh, but it's really like a sign of impending death, more or less. And also, it's very irritating to the family. So it's caused by airflow through retained secretions at the back of the throat. That's the bottom line here. Usually, we do some suction, but not deep suction, just oropharyngeal. And we usually turn the patient to one side, and usually this takes care of the problem. If it doesn't take care of the problem, we add anticholinergic agents. We use glycopyrrolate because it doesn't cross the blood-brain barrier and cause tachycardia. But if you don't have glycopyrrolate, feel free to use scopolamine or hyoscyamine or even atropine. Okay, a pericardial tamponade, or or cardiac tamponade. Uh, a better name is malignant pericardial effusion because malignant pericardial effusion or cardiac tamponade related to malignancy has a median survival of 2 to 3 months. So it has a very poor prognostic sign. All right. So I'd rather use this term if the patient has a cardiac tamponade related to malignancy. Okay, the diagnosis is usually done by looking at the symptoms of peripheral and pulmonary edema, chest discomfort, cough, shortness of breath, and orthopnea. All right. We confirm our diagnosis with an echocardiogram. And usually we treat. So this is the echo, and this is the effusion, as you see here. It's usually associated with triad called Beck's triad: distended neck veins, hypotension, and muffled heart sounds. Okay, and pulsus paradoxus. I mean, these things come in the exam, so you better try to memorize them here. Now, the how to treat is basically either doing pericardiocentesis or doing, surgical decompression, or even you can do pericardial sclerosis. Okay, the easiest one is the pericardiocentesis, and it's done if the patient has a short prognosis of less than 1 month. Otherwise, you can do surgical decompression, what we call pericardial window. And sometimes you choose not to do anything. Okay, if the patient is just in his last hours, there's no point to stick him with a needle or do anything else. Okay, this is pericardiocentesis done under echo, and this is pericardial window. Since I was anesthesiologist in my old days here, we used to do a lot of these, and usually there are emergencies. Superior vena cava syndrome is another common problem that we see in palliative setting, and it's related by the obstruction of superior vena cava, and usually happens, uh, you know, uh, secondary to lung cancer or lymphoma. Non-cancer cases are rare, but it can happen. I've seen one of them, or actually, I've seen both of these. A central line thrombosis, I've seen it. And also, I saw a case called fibrosing mediastinitis. It's not cancerous. And for some reason, patient develop fibrous tissue and it obstructs the superior vena. I had a case like this, and I was, patient used to come to our clinic for symptom management. Okay, so how we diagnose clinically edema of the face, collateral veins of the chest wall, shortness of breath, coughing, difficulty swallowing, stridor, and headache. Pemberton sign. This is Pemberton sign. Patient raises up his arm, his head start to turn red here. Okay, this is an example of superior vena cava syndrome. And the mainstay of treatment is giving steroids, do an endovascular stenting, radiation therapy, but again, the prognosis is poor. 90% of these patients die within 2 years. Okay, this is how the stent look like. Okay, bleeding in cancer patients. This is a very important topic, guys, because cancer patients, they're liable to bleeding for so many reasons. And I like this slide, to be honest with you, because it kind of wraps up the whole causes, like chemotherapy, radiation therapy, sepsis, vitamin K deficiency, hypersplenism, thrombocytopenic purpura, ITP, liver dysfunction, mucosal bleeding and bruising. Okay, bleeding in palliative setting happens in 10 to 20% of patients with advanced cancer. So this is the common palliative emergency, like hypercalcemia is very common. Okay. Um, Before anything, you need to check the patient medications, because patient might be taking a medication that helps with bleeding here. It can come with different pictures, like petechiae, purpura under the skin. It could be GI bleed. It could be intracranial bleed. It could be so many, pictures here. One of the important things to learn is to use this, recovery position, which helps the patient, if he has a GI bleed, to not to suffocate from bleeding. Okay. So how we stop bleeding with, tumors here? First, the goals of care should be explored. Reduce the anxiety with lorazepam. You can actually do palliative sedation in some situations. Use dark colored towels, okay? Because you don't want to frighten the family here. Think about radiotherapy or laser or sclerosing agent, okay? So you might need different disciplines to help you out with this. TIPS procedure for esophageal varices, okay? Pharmacologic, vitamin K, terlipressin. Terlipressin is a very important drug, and it's available in Europe, not in the United States. In the United States, they use octreotide and tranexamic acid. Of course, blood transfusions and FFP and platelet transfusions. All right? So this is how you stop the bleeding, outside bleeding. And these are the medications: tranexamic acid, um, octreotide. These are important drugs in palliative care, guys. You need to, educate yourself about them, because you're gonna use them one of these days. all right, in different, indications. This is the terlipress. This is vitamin K. TEPS procedure, which actually used for esophageal viruses that's not amenable to ligation, endoscopic ligation. So in this situation, the intervention radiologist create a channel between the portal vein and the hepatic vein, like a portosystemic shunt to reduce the pressure, in the portal circulation. And sometimes these patients develop encephalopathy. So it's a a serious procedure, but it could help out. Neutropenic fever. This is something we see all the time, and it has a specific indication, a specific definition. It's a fever, either a single oral temperature above 38.3 or a temperature above 38 that's sustained more than 1 hour, plus neutropenia. So it's a fever and neutropenia. That's why they call it neutropenic fever. Okay, with a count less than 500 cells per microliter. Um, there are risk stratification, and this one, the MACSCC index is one of them. All right. As you can see, the burden of illness, the hypotension, dehydration. A score above 21 is a low risk of complication. And usually these guys are dealt with in the outpatient setting. Score less than 21 is a high risk complication, and these patients, they need to be admitted to the hospital. Okay. Now, there is an update for the antibiotics used for neutropenic fever in the United States. The last one that I have is 2010. They use cefepime and carbapenems, a plus or minus vancomycin for higher risk patients, and amoxicillin, clavulanic acid, and Cipro for low risk patients. This is another criteria, that can be used. Okay, and as you can see, it depends on the ECOG, the COPD, chronic cardiovascular disease, and so forth, monocytes, National Cancer Institute of Common Toxicity, and stress-induced hyperglycemia. And it's basically 6 variables, and the score ranges from 0 to 8, and you can divide the patients into three risk categories: low risk, intermediate, and high risk above 3. So this is instead of the math. Some people love to use this. It's easier to use. Okay, let's jump into DVT. And DVT is usually related to what we call Virchow's triad: stasis, vessel wall injury, and hypercoagulability. So, like an example to this is having surgery. You will have stasis, patient is not moving, there will be hypercoagulability, and of course, because of the trauma, the patient will have also vessel wall injury. So this will lead to venous thromboembolism. Among patients with malignancy, VTE is one of the most leading causes of mortality. This is a common problem, guys. Okay, so again, like hypercalcemia, like bleeding or hemorrhage, it affects up to 20% of cancer patients. Okay, and we have criteria for VTE here. Clinical probability, likely or unlikely, depending on the score. If it's less than 2 or it's above 2. So these criteria are pretty important in basically diagnosing venous thromboembolism. All right, and there's another criteria for pulmonary embolism. So there's one for VTE and there's one for PE. I just put these. I mean, I don't use them really in on my daily practice here, but sometimes you have difficult cases, guys, and sometimes you need to use these, guidelines, because otherwise you might, use another. You might diagnose the patient with something else, okay, and the patient can suffer from this. So utilize them whenever you have a chance. So you always memorize that these are available for you to help you out with the diagnosis. Okay, some of the signs here, like Holman signs, Moser signs, phlegmasia albadolens, ceviolidons, all of these are manifestations of venous thromboembolism. Okay, this is the Moses test. Um, this is phlegmasia, cereoli, and albadons. This one, the leg looks completely white, and this one, bluish. These are uncommon things to see, but just, for the sake of knowing these, clinical findings can help you out with your diagnosis. Of course, doing a duplex scan is the most important thing. All right. The history and the duplex. Now, how we deal with this? Basically, it depends on whether it's an acute or short term or long term. Acute, we can use IV heparin or low molecular weight heparin, or the what we call nowadays the DUAX. Okay, these are the new ones here. Short term, basically warfarin or subcutaneous low molecular weight heparin or DOAX. For the long term, could be one of these, or could be nothing if the risk of fall is higher than the bleeding. And this is the mechanisms of action of these drugs. Uh, these are some of them: the heparin, lovenox, and warfarin. The new DOAX here, Eliquis, and rivaroxaban or Xarelto. And then these are the advantage of low molecular weight heparin over heparin. Okay, so the most important is the lower risk of heparin-induced thrombocytopenia. Okay, and the advantage of the DUAX versus the warfarin, you don't need to monitor these drugs, the new drugs here, the DUAX. So again, this is the key learning points of my presentation.